Welcome to Simcast, a podcast brought to you by the Society for Imaging Informatics in Medicine.
Hello, Simcast listeners. Today, we're chatting with Dr. David Mendelson and Chris Carr about IHE, the different profiles, the life cycle, the process, connectathons, etc. Dr. David Mendelson is the Vice Chair of Radiology IT for the Mount Sinai Health System and Associate CMIO of the Mount Sinai Doctor Faculty Practice. He has been deeply involved in the evolution of healthcare informatics and information technology since 1992. Dr. Mendelson serves on the Radiological Society of North America Radiology Informatics Committee, RIC. He is also the co-chair of the Integrating Healthcare Enterprise, IHE, International Board of Directors. He previously served on the American College of Radiology IT Informatics Committee. His current interests and responsibilities include devising a strategy to identify and integrate AI solutions for the Mount Sinai Department of Radiology. He is evaluating solutions both for diagnosis and workflow enhancement. Chris Carr is the Director of Informatics for the Radiological Society of North America, RSNA, where he has been employed for the past 25 years. He works with leaders in informatics around the world on programs that advance education, research, and technological innovation in medical imaging. Please enjoy this episode. We definitely had fun taping it. All right, Chris and Dr. Mendelson, welcome once again. Maybe we can start the conversation. For those who are unaware, can you remind us the role that IHE plays? And I would love to hear from both of you on this one, kind of from both the administrative business side and the clinical side. Maybe, Chris, we could start with you.
So I guess I'd take the administrative business perspective. But really, IHE, it started with the observation that in complex IT environments, workflow and communications between systems can't be addressed just through the standards compliance of individual systems. So IHE defines these guidance documents, really implementation guides called profiles, that describe systems in a clinical environment as actors and defines the points of connection, the transactions between them, and also the kinds of data objects they can exchange. So it's a tool for administrators and purchasers of HIT systems to put those systems together in productive, functional patterns, or, to connect them so that they work efficiently and achieve the specific clinical goals that you have. Sorry, and that bleeds into the clinical side. So
that's perfect. So let me build on Chris's answer about the details of how IHE hopes to achieve its goals of providing these workflow profiles by noting that IHE is an international organization. So I'm the co-chair of IHE International, and Chris is the secretariat of IHE International. And sitting under that umbrella are really two groups. There are the domain committees, which are the specialty committees that have knowledge of different healthcare domains. A good example for this audience would be the radiology domain. And those domains develop the profiles, which are highly technical documents, but there is an overriding discussion of the technical framework. The technical framework is the home of all these documents that explains the workflow itself, and then appropriate individuals can drill down into the technicalities of how to implement the plug-and-play solutions we aim at. Second part of the overall architecture of IHE, if you will, is the deployment committees, regional deployment committees. So there was recognition early on that there are differences in different parts of the world, different countries, different continents as well, that while everyone would like to be pretty similar, sometimes you have to refine the profile, a domain specified to the needs of a given locale. And so we have the regional deployment committees and the domain committees. which basically execute putting together these profiles and then deploying them.
So we've been talking about profiles, and actually I think profiles are unique as far as standards go. I know it's a little different, but I was hoping for our audience if we could talk more about what is a profile and what's the process of creating a profile, and even afterwards in terms of how often they're reviewed, and do we ever turn over or retire profiles?
So let me start and give an overview, and then Chris, maybe you can provide some of the more refined details. So let's say there's a problem in a given domain that everybody acknowledges. There could be a good description of how one would implement a solution, but nobody does it consistently at this point in time. So what one then does is assemble the appropriate experts, and this is all a consensus-based process in a given domain, and they sit down and at first they just outline the problem. They may sketch out a workflow diagram. This may require several months of meetings of people from the vendor community, professional societies, administrative groups, to all get together and reflect upon the problem. But once they've kind of done that schematic of what would be the best workflow, best practice, as Chris said earlier, what they then do is begin to look at the standards that exist and people use, and they begin to identify what is the best standard. So in the world of radiology, the most commonly used standards would be DICOM and HL7, today version 2, and a slow move to using FHIR. Chris, you want to elaborate perhaps a little more? Maybe give an example.
Sure. So, yeah, as David was saying, in a domain, someone originates a work item proposal, and it gets progressively built up through, kind of an iterative committee consensus process into a profile document that describes a set of actors, which might be systems or components or functional components of systems, and the transactions between them, the kind of chain of communications and the kinds of objects they exchange, the data objects they exchange. So an example, and I think we may talk more about examples later, but I'll focus on radiology. The AI results profile describes how AI systems are invoked based on the procedure information. So, what's the appropriate AI algorithm to invoke for a given procedure, and then how those systems generate and encode their information, their results, and then communicate them to the other systems, the reporting systems, PAC systems in a department, and then how those systems consume and use them and store them. And so it describes the behaviors of several different systems in this workflow. And again, the data objects that they create and exchange and how those are managed. I don't know, does that help?
Yeah, that's very helpful. But I did have another follow-up question on this. So we have all these interface engines between the different programs, right? So clearly this is not what the IHE stuff is. Is it kind of like IHE profiles are more of like the 30,000 foot or like the strategy, and then these interface engines are the actual tactics? Could you kind of elaborate a little bit more on that?
No, that could be pretty specific and pretty detailed. But we need to be careful with the use of the word interface engine because there are products that are actual interface engines. What you should understand is at the edge of each system, at the edge of each actor, those actors send out communications to other actors out there. And those need to be standards-based if we're going to have, as I referred to earlier, a plug-and-play world. So one of the earliest ones in the world of radiology was scheduled workflow. And it's so simple-minded in some ways that people might ignore it. But in fact, everybody worries about this and applies it hundreds, if not thousands of times daily in their own enterprises. In a hospital, how do you get an order into a radiology system, into a risk system? And you have to combine different systems that have to share information. So patient identity is usually established in an ADT system. So a risk system talks to an ADT system. And there are HL7 transactions generally that communicate between those two. And that's why I want to be careful about the notion of an interface engine. Interface engines help to translate when the transactions are a little bit obscured. But if things are coming out of the ADT system correctly, they can go right into the risk system. And scheduled workflow just define what's the HL7 transactions that need to cross between those two. So I hope that sheds a little more light on this.
Yeah, and I can just add that, IHE does not eliminate interface engines entirely. I think it does have the potential, and in some cases has diminished the role of interface engines per se, because as Dr. Mendelson says, it provides a predictable set of points of contact between systems. So the interface engine, that kind of normalizing layer, can become less necessary. I will say that some of the companies that develop those, unfortunately, or maybe not, still necessary utilities, interface engines, also participate very actively in IHE and, effectively use IHE as a way of standardizing their normalization layer between systems. So they adopt IHE profiles and simplify that for, sites who may have legacy systems, who may not be replacing all of their systems at once. They can use an interface engine to connect an existing system to an IHE compliant system that they acquire. Or, just those utilities will still fill a role probably for the foreseeable future. But IHE, again, gives even those a kind of standards-based foundation that makes them easier to implement and maintain and just more efficient generally.
Thank you both for the detailed answer. I did want to circle back to one part of the question I was hoping to learn a bit more about, which is we covered how IHE profiles are born, but how do they get updated? And subsequently, how do some get retired, if any?
So updating is an easier answer to provide. The various domains usually set aside some of their work to introduce change proposals as there's recognition among the participants in that domain that things have evolved over time. You brought up the subject of retirement. That was something we just recently discussed at a strategic meeting, is we haven't been so successful about allocating time to decide what to retire. Chris, other thoughts on your part for that?
Yeah, there is a process, and there is a set of maturity and performance metrics that the domain committees our guidelines instruct them to follow. And those are used both to advance newly developed profiles through the development stages, which are initially public comment. So that's when a profile is first published. It's really published to solicit outside comment. And those comments are then reconciled before a profile is published to the second stage, which is called trial implementation. And trial implementation profiles, that's the first stage at which they're used for testing at IHE Connectathons. And there is a set of metrics for how mature a trial implementation profile is, how many systems have tested it successfully at Connectathon, for example. And when it attains, in the view of the committee, a sufficient level of maturity, it then advances to what's called final text. And that's final text, forbids any breaking changes. So as David said, there's, ongoing change proposals and maintenance, but any breaking changes, so changes that would cause compliance systems to become incapable of interoperability, I guess, those are forbidden and for final text profiles. When the final text profile is either replaced by a new profile, for example, one that's adopting a new standards technology that's become current in a given domain, or just has fallen into general disuse, like hasn't been tested for a significant span of time, they can be deprecated and retired. That has happened on a number of cases. More frequently, the first case that I mentioned, where a profile is superseded, effectively replaced by a new profile that uses a different standards foundation.
So diving into this, you kind of mentioned this a little bit too, but when we talk about the standard that IHE profiles are based on, like DICOM or HL7, how do you differentiate IHE from other standard bodies like HL7 International or DICOM? Is there a parallel there, or is it that IHE really leverages these other standard bodies?
I can take that and just say IHE is kind of a meta standards organization in a sense. So it's more the latter, that it leverages what IHE describes as base standards. So, you mentioned the most widely adopted ones, HL7V2 and now HL7 Fire and DICOM, but also standards from the World Wide Web Coalition and OASIS and IEEE, and terminology standards from LOINC and SNOMED and CPT codes and others are all referenced in IHE profiles. And IHE makes a selection of the most appropriate standards to use in a given use case, and then assembles these, meta standards documents, these implementation guides called IHE profiles that address, a very specific interoperability goal in a specific clinical or operational use case.
So how does IHE update their profiles, or how does it determine when to update them based on new standards? Is it kind of a periodic review, or is it more as soon as the new standard's available, we take a look at the existing profiles to see where an applicable change can be made?
Well, to answer that question, I think you have to take one step back and understand how each domain decides what they're going to work on. And so, as Chris said, most domains do allow themselves some time across the year for maintenance. But how do they determine what new profiles they wish to develop? And that usually comes from the participating members in the domain, which again are professional organizations. So RSNA in the case of radiology, but the vendors who are very active and clearly have a vested interest in making their products work well. So they sit there and they look at, frankly, what their constituents, their consumers are looking for. So Chris mentioned the most recent work in radiology has been around AI. AI is a very active issue in the world of radiology right now. And so actually some of the radiologist members of the RSNA, but vendor representatives as well, came to the table and said that these are something that we need to work on. So sometimes what's authored, and by the way, what happens is you may get 10 different ideas, and the groups are not large enough to do 10 major pieces of work on a yearly basis. So what they usually do is go through several rounds of discussion to understand what would be involved, what needs to be done. Are there even standards out there that could address the problem that's been stated? So one is they narrow down what they're going to work on. Secondly, if something is relatively early but important, they may choose to develop a white paper before actually developing a profile. And then ultimately they develop a profile. At the same time as they develop that profile, they then look at what other profiles does this now overlap that do need to be either retired or at least, subsumed by the new work.
Add one thing to that. There is an important but somewhat fuzzy criterion that IHE uses, or principle, I guess, that it makes use of established standards. So it is important that the underlying standards, these base standards, be at a state of maturity themselves before being implemented in an IHE profile. If the underlying standards are still in a state of flux, the profiles you build on them are also not going to be stable. And that comes into play with emerging technologies like HL7 Fire. IHE has been working in developing Fire-based profiles while the various Fire resources go through their development, their evolution through a maturity metric. And that has occasioned some, going back and altering published profiles. Not when they've gotten to the final text stage, but, it has required a kind of back and forth between work on the IHE side and work on the HL7 side to refine and stabilize the underlying standards while we're working on profiles that make use of those standards.
All right. So, talking about how we use some of the other standards and whatnot, what other domains other than radiology does IHE look after? Like, do we also cover things like radiation oncology or, nephrology, or is it just pretty much focused on more imaging-based modality stuff?
What I want to focus on, and then Chris, but there's a whole list if you go to the IHE.net site, but probably from the radiology community's perspective, the IT infrastructure domain, which is a separate domain, has been extremely important to almost all the other domains because it describes, quite frankly, the plumbing that makes everything work today. But then built on top of that plumbing are very specific solutions that let different systems communicate no matter what the specialty domain. I just want to mention off the cuff what I regard as one of the most important ones in the current era when we're trying to really deliver full interoperability and prevent information blocking is the IHE Cross Enterprise Document Sharing Profile. So that's from the ITI group. The acronym is IHE-XDS. Chris, would you like to talk about some of the other domains?
Yeah, sure. I can just kind of recite the list, which, as you say, is from the website. I think there have been 12 domains total historically through IHE's, 20 plus years of existence. A couple of those are not currently active and a couple of others have kind of merged. But the ones that are currently producing specifications are the medical devices domain, devices it's just called, which has subdivisions for consumer-facing and home care devices and then hospital-based devices. There's an endoscopy domain. David mentioned IT infrastructure, pathology and laboratory medicine, which is the result of merging formerly separate domains for pathology and lab. Patient care coordination, which really focuses on developing structured documents related to various aspects of patient history. Pharmacy domain, quality research and public health, which is, you can tell from the name, has three kind of distinct directions of focus that merged into managed in a single domain. There is a domain for radiation oncology, and as we've already said, there's also a domain for radiology.
Thank you both. I think in the process of asking all these previous questions, we did name a bunch of profiles. And full disclosure, I probably know more about these profiles than most average people out there. So, I've actually had to implement some of these in the past. I know Dr. Mendelson mentioned SWIF, SWF. So SWIF is the affectionate name. And I know people have referred to it as the mother of all profiles at some point in my career. With that being said, I would love to hear from both of you and kind of some of the most prolific profiles out there, as well as maybe the ones that you're excited about them coming out. So, Dr. Mendelson, why don't we start with you this time?
Well, I've kind of named some of the ones I'm most excited about, which is XDS. And XDS-I is a special flavor of XDS for imaging. Chris and I have spent several years, I think we're close to bringing this to the finish line. XDS is the foundation that has been used most recently by the Sequoia Project in Care Equality to establish the national exchange of documents across the country from multiple enterprises. XDS is at the base of that, and another one called Cross Community Access, XCA. Those two are fundamental in really achieving the goals of interoperability that have been set in the United States by ONC and in many other countries by their regulatory groups. Radiology had recently joined that effort by adding to the Care Quality Implementation Guide, which is a very specific, rigid document about what it takes to exchange documents, and a lot of it is built around XDS. And we've added XDS-I and some specifics so that the imaging community has a good definition of what it takes to be standards compliant and enable good exchange of images. One of the other things to recognize is IHE's strength is that it does define the technical solution. But what we've learned is that to get a lot of these things out there requires a governance structure as well. And that's what the Sequoia project at Caregility has taken and applied to the technical solution that's been defined really in the IHE world.
Yeah, if it's my turn, I would add to what to David proffering XDS by adding the mobile health documents, MHD, which is an extension of that, as IHE calls it, cross-enterprise information exchange infrastructure into the world of HL7 Fire, and I think even more importantly, into the world of sort of querying for and receiving specific data elements as opposed to documents. So really shifting from the document exchange paradigm into a data element exchange paradigm. So MHD is complementary to XDS and kind of enables an additional set of use cases for querying and receiving patient information.
I'm hearing all good things about IHE profiles. And one thing that I recently found out is they aren't mandated. That's actually quite surprising because I feel like life would be easier if everyone just abided by these profiles. And I understand it gets a little complicated because we have to make sure all the standards are standard, right, among different institutions. But what promotes the adoption of IHE profiles? Is it more of the customers or the vendors who drive the conversation? Because I know vendors will provide it if customers ask for it, but sometimes customers don't know to ask for it until the vendors mention it. It seems like there's a little cyclical nature, maybe a chicken and egg type of situation there.
Yeah, professional societies do some of the marketing, if you will, to at least educate their constituents about IHE profiles. I think, however, a lot of it is the vendors bringing it to the table when they walk in to sell a system in a C-suite. There is an active testing event. We haven't discussed that much yet. We should talk a little bit about connectathons and then ultimately projectathons. But it can have a value to the purchases of this technology. It gives people some sense of comfort when a vendor comes in and says, I've been validated in an IHE testing event. So sometimes the vendors who have taken the opportunity to get their systems tested and validated will come in and use that as a piece of presenting why you should purchase their system as opposed to another one. We are, very much a voluntary organization. We would love to do more marketing, but we have limited budget for that. And we really focus most of our resources right now on the domains and development. And we try to spend a little bit of our dollars on marketing efforts, use the internet for marketing, email, distribution lists, and things along that line. So we try to educate the consumers here. Now, I sort of just provide you very much of a US perspective, but remember, IHE is an international process. And in other parts of the world, frequently the regulatory groups of different nations will be quite familiar with IHE and insist on IHE-based solutions in their RFPs. So that's another means of IHE, promulgating its solution sets.
Just to underline that, the European Commission specifies IHE profiles as requirements for a range of health IT systems in their published documentation. I would also say just that IHE provides some mechanisms for vendors to communicate their compliance with IHE profiles and for customers to get that information and to build it into RFPs. The results of connectathons are published, so you can see who has successfully tested which IHE profiles. And IHE gives vendors a form, it's called an integration statement, where they can kind of self-attest what IHE capabilities a given product has. And those statements, integration statements, are also linked in the Connectathon results database.
This brings up an interesting issue of, since IHE is an international body, how do you guys navigate and negotiate between all the different countries, laws, regulations, this and that. That's got to be kind of mind-boggling, the amount of things you guys have to take into consideration to come to an agreement upon some of these things, right?
That's the role of those regional deployment committees as well, to represent, it's kind of a feedback loop. Is the domains develop solutions, the deployment committees are supposed to provide the input in one sense and then take the output and go with it once there is an output there. The participants in all these things really represent in some ways a small world. So one, you have maybe multiple engineering talent that crosses the different standards organizations. Frequently, the participants in IHE are also the participants in HL7 and the participants in DICOM. And again, there are other organizations, the JIC of ISO. So one, there's a lot of cross-fertilization. Secondly, again, the deployment committees can say, okay, you've given me a profile. It's 90% there, but we have to add some regional definitions on this to make it work in our part of the world. And the fact that we're a volunteer organization in many ways makes people cooperative. It's a very interesting, positive dynamic that people in this organization like to work together and offer help and solutions to others who are in some ways their competitors.
Yes, and I would just, again, add one thing, which is we were talking earlier about IHE profiles, the essential specification documents that IHE publishes. Each profile document can contain a section for national extensions that adjust things to local legal frameworks or local practices. Just one simple example, I know in schedule workflow, there is a national extension specific to France because one of the data elements that's included in the patient information and DICOM data is race and ethnicity. In France, the health system is forbidden by law from acquiring and communicating health and ethnicity information. So that data element is effectively kind of redacted in the French national extension of schedule workflow. This is one simple example. But there is, this mechanism for accommodating those differences in different local care practices and legal frameworks.
Thank you both. I think I've heard enough, and you've convinced me that I need to add attending an IHE Connectathon to my bucket list. So if someone were to go to an IHE Connectathon, what are they and how do you get involved? Again, you've already convinced me. I think anyone listening to this episode is convinced. But why should someone go to a Connectathon?
This is a big testing event, and there are several across the world. The vendors are the ones who want to come and come willingly because they want to test their systems and they want to get the certificate or seals that they've completed successful testing at these events. Because again, that has a marketing value to them and providing their customer base with the reassurance that they can work with other systems. Vendors are the ones who come to the testing events predominantly, and vendors send their engineers. One vendor can easily send 10, 20 engineers if they're a large vendor testing multiple profiles. A smaller vendor may be there for only one or two profiles, and that might be one or two people. Prior to the pandemic, we would often see in person 100 plus companies at a Connectathon and up to 400 engineers in the building for a week testing with one another. As I mentioned earlier, they're bringing systems in that haven't been tested against one another yet, and that's what they have to do to be able to get a seal that they've completed successful testing. And I'll deny ever saying this, even though you have it recorded, but vendors, engineers often work with one another across the lines of another vendor to help one another pass a testing event. So there's a lot of raw code that gets refined at Connectathons. And sometimes somebody's stumped and somebody from a different organization looks over their shoulder and makes a suggestion. And this collaboration is to the benefit of everyone. multiple companies have walked out with successful testing because of the collaborative nature of this. It's really a nice thing to see, and everybody benefits from it.
Yeah, the component of it I refer to sometimes as social engineering, which is, bringing together the people, the knowledgeable people from different organizations to make the adjustments they need, help one another debug their systems, achieve interoperability. IHE Connectathons the testing has two components. There's the compliance part, which is how well does the system conform to the specification. And there's a set of test steps that it has to go through to demonstrate that. And then there's the interoperability part, which is testing with the partners, the corresponding systems present, and showing that you can effectively interoperate with them, get the information you need from them, and pass the information they need back to them. The human component of that is really important. And I would just add, there is a role for other health IT professionals to participate in Connectathons, and that is as monitors. So all of the testing is overseen by monitors who, have a detailed knowledge of the test plans and record the test results produced by each of the systems under test. There's been a great history, SIM and RSNA working together to recruit interested participants in the radiology domain. So I'm hoping that we can continue that and keep bringing people in, because it's also a good learning experience. Acting as a monitor at Connectathon really, I think, helps cement in a lot of people's minds the connections between systems and just the way that workflow needs to proceed in radiology.
And we should just note that there are international connectathons. So the IHE USA runs a connectathon, IHE Europe runs a connectathon. There have been connectathons in Korea. I believe Japan has had connectathons. Chris, am I missing a couple out there?
Sure, yeah, China, Australia.
And if I may take my Simcast host hat for a moment, I will add to what both of you gentlemen said about the Connectathons. I've had the pleasure of attending a Connectathon a long, long time ago as a vendor, and I can testify to the great atmosphere that's put together, the great organization that goes into those Connectathons. It's not an event where you show up and try and find your test partner. You've actually been prepared in advance. You show up, you already have the tools and education you need in place to hit the ground running. I've also had the pleasure of volunteering as a monitor at the most recent North American Connectathon, and also found it to be an enriching experience. Ali, I've actually been on the record on LinkedIn saying that it has to be a bucket list item for everybody in informatics to attend one of these Connectathons at least once.
By the way, we also, in recent years, have run education events as part of a Connectathon, and sometimes we kind of take bleeding edge topics, and there's a day of bringing in people who are experts, both locally, and we broadcast those as well, just as an education event.
This just keeps on getting better. Thank you.
Yeah, I'm thinking, Ali, you should try to get to one of the international Connectathons, because since it's a academic meeting sort of thing, you might be able to get your department, whatever professional funds that you have that might be able to go towards that.
All good ideas. I can't think of a better way to recruit radiologists to this work.
We would be happy to provide a letter of invitation.
Thank you.
That's great. Yeah. So one other thing that has kind of come up in things that we've talked about or thought about amongst ourselves was can you tell us about some of these other pseudo-related initiatives that are kind of on the same vein as, IHE and the Connectathons and things like that, like the HIMSS Interop Showcase or the RSNA Imaging AI practice demos? How do these all fit into the overall schema here?
It's always been partly a demonstration project. It's always had a public-facing side, and part of the incentive for testing has been, for at least some participants, preparing to participate in demonstrations at shows like the HIMSS conference or the RSNA annual meeting, and many other meetings around the world. So there's both, a marketing incentive then for companies to achieve interoperability that, reinforces that engineering incentive to be there and refine their systems and make them interoperable. And there's this element of communication of the importance to interoperability and the importance of standards in achieving interoperability out to the community, their customer base. So a lot of the purpose of those demonstrations is to instruct purchasers on how to use IHE profiles to select and connect interoperable systems.
And, HIM's interoperability showcase in the RSNA imaging AI and practice demos, and we used to do IHE profile demos at the RSNA. These are all marketing activities, but they're marketing with education in mind at the same time. So we think that we're offering a good public service through IHE. We want people to know it and understand it. And these are big marketing, initiatives. These are meetings that have 50, 60,000 people, maybe more, attending them. And it's a way of letting people who aren't necessarily that technically sophisticated or at different levels of technical sophistication get a taste of what IHE brings to the table.
I can ask a quick question. I know we're running out of time here, but who supports IHE? All these fantastic things we've heard. Is it more of a volunteer-based involvement, or is there some sort of larger foundational support?
So RSNA and HIMS are founding organizations for IHE International, and there's a membership model. And for instance, HIMS and RSNA are both considered benefactors and contribute fairly large sums of money on a yearly basis for that membership status. I'm a local department representative. I pay membership dues, which are not, my membership dues are far from onerous. I believe last year was on the order of $300, and I represent the Mount Sinai Department of Radiology. So that's one of the ways funds come in. The domains are sponsored by various organizations, sometimes vendors, sometimes professional. They just pay the equivalent of secretariat charges to organize meetings. But not to be lost in all this is the volunteer work here. So all the profile development is voluntary. There's nobody paying anybody for any of the work done. This is, again, I like to use the term public good. People have recognized that a profile would be useful, would help the overall community. Yes, and vendors are going to market products around that and make revenue from that. But the work on developing the profile is totally voluntary.
To add what Dave's saying, the membership organizations in IHE, there are over 100 in the really four categories: government and nonprofit, health, IT, and consulting companies, which is the largest in terms of number of members, health care provider organizations. So, if you're representing a hospital or a department within a hospital, I think, for example, that's David participates. And other standards development organizations are also members of IHE. Just to make a pitch, as David mentioned, the membership fees are quite reasonable relative to other standards organizations' fees, and they include, once you're a member, you can become a participant in any of the domain committees, and you can participate in the proposal and selection of work items and the development of profiles. It is kind of fairly democratic consensus process, and it's open to all the member organizations.
And especially as SIM broadens its outreach and has an extended membership, an expanded membership well beyond radiology, understand that once you're an IHE member, as Chris said, you're not restricted to any one domain. So if you have opinions or you think you can contribute to these different domains, you're free to join and work through any of them.
Excellent. Thank you both so much. It's been an informative episode. So we are going to get ready to close the episode and would love to get any last thoughts from both of you, including maybe tell our listeners, how can somebody pitch an idea or provide any kind of feedback to IHE? So Chris, maybe we'll start with you this time.
Sure. Well, as I mentioned, if you become a member, you are then eligible to be a fully participating committee participant. And you can propose work items in the regular schedule of the domains in which you're participating. And then more broadly, even if you're not a member, when new profiles are published, You can subscribe to the activities of a given domain and participate in the public comment period for new profiles.
I would encourage people to participate, understanding that we're in some ways a small organization and we're not driven by revenue and money, so to speak. And yet we're recognized worldwide because we're, I think, viewed as an honest broker, as an agnostic partner that really tries to do the right thing and has the interest of the patient at the bottom of all of this, at the heart of the activity. If we can deliver cost-effective, excellent solutions and we can contribute to vendors doing that and healthcare enterprises purchasing those solutions, then we've really done a good thing, because healthcare is expensive. And this is a rational way of rationalizing costs, if you will, and keeping them within reason.
Perfect. Thank you so much. Really appreciate the time both of you took to speak to us today. I think this is going to be a very interesting episode for our listeners. I secretly hope it's probably going to be one of our most popular, if not the most popular.
I'm going to mandate that my grandchildren listen, but the oldest one is 3. So I'm not sure. We'll brainwash her.
Got to start them early.
Yeah.
That's right.
Thanks for the opportunity, folks.
Thanks, you guys.
Thank you all. Have a great day.
Bye-bye.
Simcast has been brought to you by the Society of Imaging Informatics in Medicine. Please visit our website at siim.org for more information and educational content, including webinars and an archive of prior episodes. Please follow us on Twitter at sim_tweets. Thank you to our listeners for your continued support.